Good evening, students. Okay, we are continuing with our lecture series. I suppose we know that we're supposed to have seminar, right? And I suppose we've been given some topics to read around. Okay, who are supposed to present the seminars? How many presentations do we have? Or you're not prepared? Who is the class rep? Okay, the HOD sent me a message, containing the lectures that your people are supposed to prepare for seminar. Were you informed?
Yes, sir.
Okay, so they are saying they are not prepared.
Someone said some are prepared.
Some are prepared. How many topics were given out?
For today, we are meant to talk about the psychopharmacology, anxiety, antidepressant, mood stabilizer. These are the three subtopics.
But this particular lecture is on schizophrenia. No, that's not what I have in the lecture schedule. Do you have the lecture schedule with you? Go to your lecture schedule so that we'll know what we have. You have it there? Sorry, by the way, my name is Dr. Lisa. My name is Dr. Lisa. I'm a consultant psychiatrist. What's the noise about? He said? Who is Olisa? Please stand up. Let me see my. Why are you clapping now? What are you talking about? Oh, is that your first name or surname? First name or surname? Huh? What? Middle name. Okay. Mine is surname. So, have you seen it? What are we supposed to have? Schizophrenia. And you appear based. Maybe you are going to be the one that will deliver the lecture. Are you prepared? It's okay, no problem. We'll see how we do it. But I suppose you guys have gone through schizophrenia, because schizophrenia is one of the most important topics in psychiatry. Have you heard about the term schizophrenia? Okay, I like my lectures to be interactive, so I'm going to be interactive. So please, you're tired? No break. Don't worry, we are going to make it short. We are going to make it short. I'm here based on the communication I got from the HOD who just had lecture with you. So we'll see how we are going to do it. So, have you heard about the term psychosis? Can somebody help us? What is psychosis? Because for you to be able to understand schizophrenia, you have to understand what psychosis is. Schizophrenia is a major psychotic disorder. So, what's psychosis?
Tactile, visual hallucinations or experiences with things or beings that can only be seen by the patient. Like, it's very subjective.
Okay, that's a good tryout. You gave us the symptoms of schizophrenia or psychosis. But what's psychosis? Even before you came for this lecture, you must have heard the term psychotic. It's like you're psychotic. You can even use it to insult somebody. So psychosis simply means loss of touch with reality. I hope you have your notes. I like dictating. And after the lecture, I'm going to ask questions. So please try and pay attention. I understand that some of you might be hypoglycemic, but we want to make the lecture as lively as possible. So psychosis means loss of touch with reality. So in other words, it means that the person is a different reality. The person appears to be in a different world, having different experiences that other people, other apparently normal people do not have. So psychosis means loss of touch with reality, or alteration of reality, or distortion of reality. So you can use that description to explain what psychosis is. And now psychosis is characterized by key symptoms such as delusions, hallucinations, disorganized speech, disorganized behavior, negative symptoms. Did you get it? You didn't get it. Should I come again? So psychosis is described as alteration of reality, or loss of touch with reality, or distortion of reality, which is characterized by delusions, hallucinations, disorganized speech, disorganized behavior, negative symptoms. So that is it. So I believe that some of you are able to, get it. So you can meet with someone that is faster at jotting down dictations. So that is what psychosis is. Now, schizophrenia is a major psychotic disorder. Just like I said, before you can understand what schizophrenia is, you have to first of all understand what psychosis is. So schizophrenia is a form of psychotic disorder. In fact, you can say that schizophrenia is one of the most severe forms of psychotic disorder. It's actually the most important psychotic disorder that is characterized by psychotic symptoms and again impairments of various domains of functioning. Schizophrenia is one of the severe forms, or one of the severest forms of psychotic disorder that is characterized by delusions, hallucinations, disorganized speech, disorganized behavior, and that is associated with impairments in various aspects of functioning, such as personal functioning, family functioning, interpersonal functioning, occupational functioning, and functioning in broad social context. For something to be a disorder, there has to be impairment of functioning. Do you understand that? And that is very important for us to know that behavior is a continuum. There is a thin line between normality of behavior and abnormality of behavior. So for you to say that something is abnormal or that something constitutes a disorder, there has to be impairments in domains of functioning. And not just impairment, the disorder involved is associated with distress, either to person that is suffering it or people around. Do you understand that? Do you understand that? So we are trying to say that schizophrenia is a disorder, is a psychotic disorder, and I'm trying to explain what a disorder is. So for you to call a behavioral syndrome a disorder, is associated with impairment of functioning, personal functioning. For instance, somebody who is schizophrenic might not be able to take care of their personal hygiene. Two of us, you see the person dirty. That is impairment of function, personal functioning. Now, impairment of interpersonal functioning or family functioning. Example is somebody who has schizophrenia might have what we call delusion. Having thoughts, I'll still define some of those terms. Delusion means having false belief. So the person can believe that, oh, they want to poison me, they want to attack me, they hate me. So what is it going to have to the person's interpersonal function? It's going to be impaired. Because if I believe that you're my enemy, if I believe you want to attack me, it's either I withdraw from you, I won't want to talk to you again, or I attack you. So that is impairment in interpersonal functioning or family functioning. Because for somebody who has schizophrenia in the family, might have chaos. They will tell you, oh, this person has been pursuing us with knife, has been trying to, beat us up and all that. Now, there's also impairment in occupational functioning. When we go to the social theory of the schizophrenia, you see that people who have schizophrenia, if they are not treated, they have what we call social drift. They drift down. I know that many of you may have read the time that schizophrenia, or the period that schizophrenia starts, is around adolescence or early adulthood. So somebody who starts to manifest schizophrenia, if the person was doing well, for instance, a medical student, before you know it, the person will start drifting down. Stop attending lectures, staying on their own and things like that. So that is impairment in functioning. Now the other one is what? Let me know the people that are listening. I mentioned like 5 domains. What's the last one? Yeah, impairment in social functioning or broader social context. For instance, as a normal person, you have organizations where you belong. Maybe if you travel home, some belong to Omona, some belong to age groups, some have churches, societies in the church that they belong to. So that is functioning in broad social context. So somebody who has schizophrenia, depending on the kind of symptoms that the person has, might not be able to attend to the person's social life or social needs. So you're going to have a drift. So that's that. Now, let's now go to the key symptoms of schizophrenia or psychotic disorder. We mentioned about 3 or 4 of them. Can somebody help us? When everybody is talking, nobody is talking. One symptom domain of schizophrenia. Delusion. Okay. Which other one? Okay. Yes, disorganized speech and behavior and catatonia or negative symptoms. So now let's go to the first one, delusion. Can somebody help us with the meaning of delusion? What do you understand by delusion? You are raising your hand. Volunteer. Delusion. It's a normal word now. It's an English word. Okay. It's a false belief not based on reality. Okay. I give you 50%. Can somebody else help us add flesh to it so that it will make a psychopathological meaning? You know, we're talking about psychopathology. Okay. Is it? Okay. So I want you to jot it down now. Delusion is a false, fixed, and unshakable belief. A delusion is a false, fixed, and unshakable belief, strongly held by an individual despite evidence of it not being true, and which is not in keeping with the person's context. Okay? A delusion is a false, fixed, and unshakable belief, strongly held by an individual despite evidence that it is not true, or despite evidence to the contrary, and which is not in keeping with the person's background or context. which is not in keeping with the person's background or context. So in brackets, that context, you have to expand it. It could be religious context, it could be socio-cultural context, it could be academic context, educational context, and other belief. So the person that gave us a definition, you can see that this one is more expanded. So a delusion is not just a false belief. If you say delusion is a false belief, that means virtually everybody here can be said to have some form of delusion or the other, because many of us have false beliefs based on our exposure, based on, you cannot know more than what you know. Let me put it that way. You can only talk about what you know. So, and something that you don't know very well, you're more likely to hold certain false beliefs. But that doesn't make it a delusion. Delusion is a symptom of mental illness. It only occurs in the context of mental illness. So now, it's not only a false belief, it's fixed and unshakable. Meaning that when you prefer alternative explanation to the person still holds fixedly to that belief system. It's not amenable to reasoning. You might hold a particular belief system based on the information you have. But when somebody tells you, no, it's not like that, so see how it is, and the person gives you evidence for you to jettison that belief that you have, you now have to. That's how a normal person. But for somebody who has psychosis, the person holds onto it fixedly, despite evidence that it is not true. And now, it's not just that. This is not in keeping with the person's background. Meaning there is no reason why the person should have this belief. Based on the person's educational background, based on the person's cultural background, based on the person's religious background. I'll give you an example. Like in some cultural backgrounds, like fathers and mothers and foremothers in the villages, there are certain belief systems that they hold. We call those things superstitions, right? Any little thing that happens, they are attacking you. They give it a spiritual connotation. They give it a diabolical connotation. Is that not true? So, will you call it a delusion? That kind of a delusion, that kind of thinking a delusion? It's not a delusion. We call it overvalued idea. These are belief systems that are held fixedly, but they have cultural undertone. You can understand it based on the person's context. Then again, in religious cycle, manipulation by evil spirits and all those kind of beliefs are prevalent. But we know, as people who are educated, that it's not the way they explain it that it is. But you can understand it based on the person's religious context. So, for you to call something a delusion, it means that belief must have been subjected to all these other contexts. The belief is not explained by the person's religious inclination. It's not explained by the person's social inclination. It's not explained by the person's cultural inclination. And yet the person holds onto it. And it's strange to people around. They understand. They will be like, for instance, somebody will tell you, my mother wants to poison me, and that's why I'm attacking her. A schizophrenic patient can say that. In fact, we've had cases of schizophrenic patients killing their parents. Although this is not too common, but it has happened. Why? Because of this delusional belief system. Delusional belief system that the parent involved is trying to harm him. So, and how do you shake it? If somebody tells you, my brother wants to kill me, my father wants to kill me, how are you sure? Remember the definition of delusion, you have to shake it. You have to check the fixity. Is the person fixed? And how do you do that? I challenge you. How can it be that your mom who carried you for 9 months is now the one that is trying to say, no, I know. The person goes on to it. So that's a delusion. Is that clear? Any question? So you can see that it's not any false belief that is fixed, that is a delusion. First of all, it has to be false, it has to be fixed. And it does not make sense in the person's context. That's when you call it a delusion. And delusion is only seen in mental illness. When we discuss hallucination now, you will not, let me ask you, are there hallucinatory experiences that can be found in normal persons? Give me an example. When you take it, the person that took Igbo is no longer normal now. Substance intoxication is under mental illness. You hear your name, right? Maybe you're waking up from sleep. You're waking up from sleep or you're falling asleep and you hear somebody call you. We call that hypnagogic and hypnopompic hallucination. Have you done narcolepsy in neurology? What class are you? Which is this 600 level or 500 level? 500. Okay, you still do in neurology. They will teach you narcolepsy. So there is a kind of hallucinatory experience that somebody hears or experiences when the person has altered sensorium. You know what altered sensorium is? Your consciousness is not stable. For instance, you're falling asleep. You're already drowsy. You have altered levels. So you can hear something. You can hear your name being called, or you can see something. It doesn't mean that you have mental illness. So we have called those ones hypnagogic and hypnopompic hallucinations. Later you could read around them. Then in bereavement, you know about bereavement. Somebody who lose somebody that is close to you, and you're pained, emotionally pained, disturbed. You can hear the voice of that person. You can even see the person in a flash. It's common in bereavement, as in tongue bereavement. It doesn't suggest mental illness. So this may be tested in MCQ. Which of these are associated with normal health? Delusions, hallucinations, and other things. Which of these can be associated with hallucination? But delusion is almost pathognomonic of mental illness. So, do you know about types of hallucinations that can be found in schizophrenia? Types of hallucinations. Can somebody help us? Auditory hallucination. What else? Visual hallucination. Gustatory. From this side. Somebody should rescue this side. Olfactory. Okay. Tactile. So, you mean, what is hallucination? Hallucination is perception in the absence of stimulus. Hallucination is perception in absence of stimulus. You are perceiving something from any of your sense organs when there is no stimulus. You're hearing your name being called when nobody is calling you. You're seeing something that other people are not seeing. You're tasting something that is strange, that is not explained by, maybe you eating something. You're perceiving something that only you is perceiving. So, perception in absence of real stimulus is called hallucination. What about illusion? Illusion. Can somebody help us?
Based on the person's own perception and perception.
Okay, now in illusion, there is a percept, there is an object, but it is misinterpreted. Did you get the difference? In hallucination, there is nothing. There is no object, but you're perceiving something. Your mind is perceiving something. Just like in auditory hallucination. Somebody is hearing voices of people that are not there. He's the only one hearing those voices. Meaning that there is a perception in the absence of a real stimulus. But in illusion, there is an object, or they call it percept. There is a percept, but there is misinterpretation of that percept. I give you an example, and now this thing can also happen in altered sensorium. A typical one is, when you go to large farms, Some farmers used to hang clothes, pieces of cloth on sticks. What do they use that to do? Okay. So now, if perchance you go to such a farm when it's dark, do you understand? You didn't know about those things. What do you think will happen?
You will think it's a man.
No, a man what? Spirit now. If I think it's a spirit now, you start running, but even get disturbed. So there's a percept, there's an object there, but it's being misinterpreted. There's actually something, just that because of the state of the mind of that person, and again because of the altered perception or altered sensory stimulus, the person is now interpreting it as something else. So that one can also happen in normal health, in normal mental health. So that's that. So now there are types of hallucinations, just like you said, auditory hallucination. Which kind of hallucination is the commonest? No, in functional mental conditions. That's not correct. Auditory. When we talk about, you can divide mental disorders broadly into two classes: functional mental disorders or psychiatric disorders, and organic psychiatric disorders. Have you been taught this kind of division? Now, functional means that, okay, let's start with organic. Organic means that there is a demonstrable systemic problem that can explain the mental disturbance. A typical example is hepatic encephalopathy, uremic encephalopathy. Are we familiar with these terms? Do you understand? HIV-associated encephalopathy. Do you understand? Is that what again? CVS. Syphilis, yeah, neurosyphilis. What is it called? That neurosyphilis. What's another name for neurosyphilis? General paralysis of insane. Have you heard about that before? General paralysis of insane. That's tertiary syphilis that is affecting the brain. Then dementias are also forms of organic mental condition, because whenever you screen the person, you will see some systemic issues. Even substance-induced psychotic disorders, they are organic, because the person is having impairments or alteration in behavior or thinking process because there is a particular system that is not functioning properly. This is different from organic psychiatric, functional psychiatric conditions. In functional psychiatric conditions, at times you may not be able to pinpoint, just like schizophrenia. By the time we go to the etiology of schizophrenia, you see that there are so many things that are involved. It's not necessarily as a result of brain pathology, because most people that have schizophrenia, when you check their brain looks normal, but they still have issues. So for functional psychiatric conditions, you are more likely to see auditory hallucinations. Visual hallucinations are commoner in organic psychiatric conditions. Is that clear? Is that clear? Yes, because it can come out in MCQ. Which of these are commoner in organic psychiatric conditions? Visual hallucination, auditory hallucination, tactile hallucination. It's visual hallucination. But for non-functional psychiatric conditions, for functional psychiatric conditions, non-functional is organic. For functional, it's most likely auditory hallucination. So now, auditory hallucinations are also classed. I think I have to sit down. Ask your question. You can interrupt me anytime. Look, I said that psychiatric conditions can be broadly classified into two categories based on etiology. Do you understand? You have organic psychiatric conditions and functional psychiatric conditions. Did you understand that one? Organic psychiatric conditions, can be caused by demonstrable organic pathologies in any system. And I gave instances: uremia, where you have chronic renal failure, and all those uremic toxins are bombarding the brain. Hepatic encephalopathy, HIV-associated encephalopathy, dementias, substance-induced psychotic disorder. These are organic. I'm saying that visual hallucinations are commoner in organic psychiatric conditions, whereas in non-organic or functional psychiatric conditions is auditory hallucinations. That is how it is. That is how it is. So just take it that way. At times some of these things cannot be easily explained, but just know it. It's a point of MCQ. Yeah. So now, for auditory hallucinations that can be found in schizophrenia, there are 3 types of auditory hallucinations. Can somebody help us? Types of auditory hallucination. First person. Yeah, I've heard about this first person a lot. I don't know about first person. No, some people claim there is first person. So second person, can somebody give me a, because now it's not good to cramp these things. Okay, it's like the HOD. Okay, so let's not go through those, because we still have a lot of things. So you have second person where the voice or the voices are using you are a fool, you are this, you are that. You have third person where the voices are discussing the person in the third person. He, she, look at him, look at her, and other things. So, or the voice can also use they. So now, which one has more diagnostic weight? No, it's not true. Third person auditory hallucinations have more diagnostic weight than second person auditory hallucinations. Do you understand? So initially, we used to have something that is called first-rank symptoms of schizophrenia. Has it been taught? First-rank symptoms of schizophrenia. So in first-rank symptoms, these are symptoms or symptom clusters that once you pick any of them, it is more likely schizophrenia. There are a lot of mental health issues. You have bipolar disorder, you have depression with psychotic symptoms, you have mania with psychotic symptoms, you have delusional disorders. There are so many of them, and that's why when you make a diagnosis, you always have differentials. So first-rank symptoms of schizophrenia are in such a way that once you pick one, the diagnostic specificity of schizophrenia increases. And one of them is third person auditory hallucination. It's one of the first-rank symptoms. So when you pick it, it's more likely to be schizophrenia than other conditions. But you can still have it in mania, you can still have it in depression, but it's more in keeping with schizophrenia. So that's that. So for auditory hallucinations, we have second person, third person, and command, right? Where the voice is commanding a person to, and it has. When somebody has command auditory hallucination, what do you think? What's the implication? The person can be aggressive, especially if the person obeys whatever the voice says. The person can be aggressive. So that's that. Now, delusions. Have you been taught types of delusions? Can somebody mention them? No, not only you. Types of delusion. Okay. Delusion of grandeur or grandiose delusion. At the back. Those at the back. I don't know what's happening. That back row. Somebody should answer. Huh? The back row. Oga. Can you stand up? Yeah, stand up. So, delusion of love, okay. Another name is what? No, erotomania. Erotomania. That's another name. Which other type of delusion? Those are the back. Someone has mentioned it. The fair lady. Yeah. Is your mind here? What question did I ask? Types of delusion. Which one do you know? Which one do you know? Delusion of love. Okay, so you have the commoner ones are, you can sit down. Persecutory delusion or paranoid delusion, grandiose delusion or delusion of grandeur, nihilistic delusion, nihilism. Nihilism means absence of something, that when somebody believes that something is absent when it is present. Delusion of non-existence. For instance, somebody who has schizophrenia can tell you, my intestines are rotten, my intestines are no longer there. Do you understand? Again, somebody who is depressed can also have nihilistic delusion. Then what else? You have delusion of jealousy, where you thought that. Okay, what's another name for delusion of jealousy? Othello syndrome. Othello. These things are asked in MCQ. They are asked in MCQ, so pay attention. Othello. Ottello. Othello syndrome. So these are types of delusions. But the classic ones that are commoner, you even have religious delusions. You even have delusions of reference. Okay, delusion of poverty. Have you heard about delusion of reference? In delusion, who said referential?
They feel like they are talking about it.
Okay, yes, something like that. Something is not referring to you, and you said that thing is referring to you. For instance, now you're watching the TV, and there is a church program going on, somebody preaching. I now say, oh, this preacher is talking about me. In fact, some schizophrenic patients have smashed TV screens because of that delusion of reference. Or you are passing by, you see people talking, you conclude they are talking about you. That's delusion of reference. So, in all these things, the principal ones that are commonly found in schizophrenia are delusion of persecution. That's persecutory delusion. You have delusion of reference. Then you also have what? No. Nihilistic can be found, but it's commoner in depression. Grandiose delusion. But grandiose delusion is commoner in mania. But it can be found in schizophrenia. But the difference between grandiose delusion found in mania and the one found in schizophrenia is that the one found in schizophrenia exhibits what we call double orientation. Double orientation means that the person is direct opposite of what he is claiming. Somebody can tell you, I'm the king. The schizophrenic person can tell you, I'm the king here. And you see the king wearing tattered clothes. That is double orientation. But somebody who is manic will dress gorgeously. Do you understand? And be talking with authority. That's the difference. Is it clear? So I said, grandiose delusion can be found in. Okay, let me dictate. Grandiose delusion can be found in both schizophrenia and mania. But the difference is that grandiose delusion found in schizophrenia exhibits a phenomenon called double orientation. Double orientation means that the individual's behavior is a direct opposite of what he claims. Do you understand? Whereas somebody who has mania would want to act it. Do you understand? So that's that. So which other symptom of schizophrenia have we not discussed? Okay, no, before catatonia. Disorganized speech. Have they taught you formal thought disorders? Okay. Now, disorganized speech is a function of disorganized thought. And that's why in Facebook they will tell you disorganized speech / disorganized thought. The way you talk or the way you speak is a reflection of the way you think. Is that clear? So that's why we call them disorders of thought. Now, under disorders of thought, we have 4 categories. I will list them, so copy them. disorder of thought flow, disorder of thought flow, disorder of thought form, disorder of thought content, and disorder of thought possession. Is that clear? Who is saying no? Which one didn't you get? Let me come again. We are talking about disorders of, delusion is a disorder of thought. When we are talking about delusion, is about thinking. So, and we are saying that in schizophrenia there are several categories. You have delusions, you have hallucinations, you have disorganized speech / disorganized thought or thinking, then you have disorganized behavior, catatonic symptoms and negative symptoms. So we are now under disorganized speech. And I'm saying that disorganized speech can also be called disorganized thought, because thought speech is a reflection of thought. Is that clear? So now disorders of thought has 4 categories. Disorder of thought flow or thought stream, disorder of thought form, disorder of thought content, and disorder of thought possession. Oga, can you repeat what I said? The person of Mufti. Did you copy it? Did you copy what I said? No, the person of Mufti. The second to the last row. Yes. Where is your notes? You have magnetic brain. Okay, the lady at the back. Can you repeat what I said? No. At the back. Stand up. Your mind has to be here. Okay, so repeat what I did. You just were able to get it? Why didn't you write it down? You don't have a note, or you're distracted? Which one? Before I started this lecture, I said this lecture is, it's supposed to be a seminar. You are supposed to be the ones teaching me, but you didn't prepare. And me too, I didn't prepare much. I didn't come with laptop, so I was told that the topics have been given to you people to present. So what is the problem? You couldn't get it. Which one were you able to capture? Did you jot down anyone? No, read it from what you jotted. You didn't jot. What's the problem now? This disorder of thought what? Thought flow, okay. 1. Thought form, Thought content, Possession. Why were you not talking now? As if, what's the problem now? You are not confident. I thought maybe you are not listening. It's okay, so you can sit down. So now, under thought flow or stream, is about the flow, the pattern of flow of speech. Now, it has, it's a continuum. You have the high, you have the low. From the high, you have pressured speech. Under disorder of thought flow or disorder of thought stream, the high end is pressured speech. Pressured speech. Pressured speech means that the person is talking too rapidly that you cannot stop the person. It's characteristically seen in mania. People that have mania, they talk too much. You can also have it in schizophrenia. Do you understand? So pressured speech is that the person, the rapidity of speech is so high that you cannot interrupt the person. Yes? He said? The difference between mania is a mood disorder. Do you understand? Why schizophrenia is a psychotic disorder? But that's globally. But mania can still have psychosis. You can have psychosis in mania. Do you understand? So, but mania principally is a mood disorder where somebody has something like happiness, excessive happiness for no reason, being excessively active, spends a lot, being disinhibited sexually, everything is high. Do you understand? So, but when it becomes severe, you now have mania with psychosis. And when you have mania with psychosis, the symptoms can even be similar to schizophrenia. Do you understand? So why did we stop? So the person cannot be interrupted. That's the high end. Now, the middle end is that the flow is okay. It's neither rapid nor too slow. Now, at the low end, you have poverty of thought or poverty of speech. Is that clear? We started from the high end, pressure speech, normal flow. The low end, you have poverty of speech or poverty of thought. It means that the person is not flowing. The person has abnormal hesitation. And it's not explained by the person not knowing it. Just like I've been asking you some questions now, and some of you have been like, wow, I've not heard about it. So if I ask you to, discuss a psychiatric concept that is not been taught or you don't know well, you have hesitations. Is that not? No, but it's not. So the poverty of content or poverty of flow is not explained by you not knowing it. You know that thing, but for some reason, there are hesitations. Now, the last end, that's the low end, is thought block. Thought block. I'll ask questions again. No. If your mind is not here, I'll ask questions. No, the low end, that's the extreme. If there's anything like that, extreme low. Do you understand? It's thought block. The person has long hesitation. And now that thought block can be explained by another concept called thought withdrawal. Did they teach you thought withdrawal? The explanation is usually delusional. You're flowing with somebody and suddenly the person stops. The person is not talking again. I ask the person, why are you not talking? The person tells you, they have taken away my thoughts. Some external forces have taken away my thoughts. And that's why I cannot flow again. You are laughing. Is that funny? That's so. Let me list it again. The extreme high is what? Pressure speech or pressure of speech. Then the normal flow. Then poverty of thought or speech. Then thought block. Do you understand? So that's that. So let's now go to the next disorder. Former thought disorder. Disorder of form or former thought disorder. Disorder of form or former thought disorder. So disorder of form is the nature or the pattern of speech. That is why you have things like circumstantiality, tangentiality. Are they strange? Okay, you've been taught that. So circumstance. Okay, so you people should help me. Under former thought disorder, so mention two. Derangement, tangentiality. Who? Oga? Hello? The person on time. Types, forms of disorders of speech. You looked at me and you're writing again. I'm talking to you. We are talking about former thought disorders. And somebody has mentioned tangentiality, derailment, circumstantiality. Which other one do you know? Just relax. You mustn't know it. I just want you to pay attention. Continuity. I don't know about that one. Okay, can you help us? discontinuity. Okay, so you have circumstantiality. Later people should go and read the meanings. So, and these things can be seen in schizophrenia: tangentiality, circumstantiality, derailment, incoherent speech or losing of association. You have verbigration. You have word salad. Verbigration. Verb. verbigeration. Verbigration. So, word salad. Word salad is the extreme. Extreme for word salad. Word salad. The person is just jumbling words without making meaning. And you also have neologism. Neologism. Have you heard about it before? Neologism means a patient inventing their own word. That word does not have meaning to a normal person. It's only the person that knows the word. Neologism. Neologism. So let's stop here. Now you also have disorders of thought content. Disorders of thought content. That is where you have delusion. That is where you have delusion. You also have preoccupations there. Delusions, preoccupations, and obsessions. Maybe during our next lectures we'll talk about them. Then you also have delusion of thought possession. Delusion of thought possession. That is where you have thought broadcast, thought withdrawal, thought insertion, thought echo. But there is a problem with thought echo. There is a controversy about thought echo. What is thought echo? Okay, there are two forms. One is you're thinking something, you're hearing it. Or you hear the thing shortly after you thought it. Do you understand? That's thought echo. But some people are saying there is a perceptual experience, not a thought experience. Do you understand? Because it's about perception. That is actually a misnomer being, categorized under thought disorders of thought possession. So, can somebody read out their notes about this classification now? Who got it? Who got everything well? Who are the great note takers here? Who is Amarachi? Amarachi, classify disorders of thought according to what we. Please, no noise. We don't need noise.
Disorder of thought possession. So thought flow is about the pattern of speech flow. There is pressurized speech, that's the person talks rapidly. It's mostly seen in mania, but also seen in schizophrenia.
Okay. Continue.
From the middle, okay, that is for the high end. Then in the middle end, the flow of speech is okay. Then from the low end, there is poverty of speech or thought. Then the extremely low end, there is thought flow. It is explained by thought withdrawal. Then for the sort of thought form, examples you have derangement,
derailment, not derangement. Derailment. So continue.
Substantiality, incoherent speech, verbigration, word salad, neologism. That's the person inventing your own word.
Okay.
Then sort of thought content, there is delusion, preoccupation, and obsession. Then for thought possession, there is thought withdrawal, thought echo, and
thought insertion and thought broadcast. Okay. So let's stop at that. No. Don't worry. Okay, how many lectures have you had today? But we've not even touched this here. How are we going to cover this? Because whether you like it or not, we are going to set it in the exam. Tomorrow, are you going to pay me for that? I'm not supposed to come tomorrow. There's some other lecture. It's supposed to be from 2:30 to 4:30, but I will make it 4. So just 30 minutes. Let's rush. Training to be a medical doctor is not easy. It's not an easy one. So it's okay. So we now go to etiology of schizophrenia. Etiology. Okay, you have a question? Please, please. Okay. You're just talking and not thinking. That's a psychiatric disorder. I said generally, your speech pattern is reflective of your thought pattern, generally speaking. Or don't you, before you ask me this question, didn't you think about it? That's what I'm saying. That is why they say disorders of thought / disorders of speech. They can be used interchangeably. And I'm telling you why they can be used interchangeably. Because the way you talk is reflective of the way you think. There may be some people that can be talking without thinking. Well, maybe you come up with the term to use to describe it. So just hold it there for now. Okay, now etiology of schizophrenia. Etiology of schizophrenia. Generally speaking, mental health conditions have diverse etiologies. Generally speaking, mental health disorders or mental disorders have diverse etiologies. But principally, the etiologies can be explained by a combination of genetic and environmental factors. And this concept has been previously described as nature-nurture interaction. Nature-nurture interaction. Is that clear? I said, generally speaking, mental disorder, the etiological or etiologies of mental health disorders are multifactorial, but principally or broadly, they can be as a result of interaction between the genes and environment. The genes and environment, which has been described as nature-nurture interaction. Now, nature means your genetic makeup. Nurture means your environmental exposures. Is that clear? So what we are saying is that the etiological factors are multifactorial. So it's a combination of your genetic factors and environment. So, and that holds true for schizophrenia. Now, under etiological factors, there are certain genetic abnormalities. Are you jotting? Okay. Our key, how do I describe you now? So, generally speaking, the genetic factors are as a result of abnormalities in certain genes called candidate genes for schizophrenia. Or single nucleotide polymorphisms. Did people do genetics? In biochemistry. You know about SMPs and CMVs. You know, in clinical sciences, you apply preclinical knowledge. So all those biochemistry, physiology, and anatomy, in your clinical classes, it is expected that you apply them. So what we are saying is that there is something that is called single nucleotide polymorphisms. These are minor differences or minor variations in the sequence of are nucleotides. You may not jot down this one. If you know it, you know it. If you don't know it, maybe later you meet the people. Am I talking in jargons? Yeah. So the changes, minor changes or minor variations in the sequence of our genes explain why we are not exactly the same, except for the monozygotic twins. Monozygotic twins are exactly the same genetically. So, but for other persons, we are different. Some are short, some are tall, some are fat, some, different variations. This can be explained by minor differences in the sequence of certain nucleotides. And now, in the pathophysiology of schizophrenia, now let me ask you, what is the most important neurotransmitter that is involved in schizophrenia? Dopamine. Now, so what happens is that for some persons, the level of their dopamine is higher than others. For some persons, the sensitivity of the dopaminergic receptors are different. Do you understand? The way, there are key things. One is the level of dopamine. The second one is the receptor, the nature of receptors. The third one is the reuptake process. These are the three major things that are involved. Release of dopamine, it can be high, it can be low. Sensitivity of receptors, dopamine has to bind on receptors to be able to elicit biological function. Now, after it has bound on receptors, after some time, it's reuptaken back into the synaptic cleft. This is basic physiology. Now, there are some proteins that are involved in the uptake of dopamine. Now, all these things we are talking about are determined by genes. There are genes responsible for production of dopamine and other neurotransmitters. There are genes responsible for production of receptors, which are proteins, integral proteins. There are genes responsible for reuptake of dopamine and serotonin after they finished working. So, if these minor differences in these genes are clinically significant, maybe there is substitution. You know about codon. What is codon? What is a codon? It's not a pet. Three bases. Is that not? Adenine, guanine, and all those stuff. Now, maybe at the top point, there is a substitution. Adenine substitutes for guanine, or the other way around. Now, those minor substitutions, they can be clinically significant or clinically not significant when you know about degeneracy of code. Degeneracy of code or redundancy of code. What it means is that a particular codon, several codons can code for same amino acid. Do you understand? Or the same protein. Now, if the substitution results in a similar, codon that gives rise to the same amino acid, there won't be any problem. Is that not? Or that gives rise to a similar amino acid, there won't be any problem. But if the substitution, for instance, results in a totally different amino acid, there will be a problem. So this is single nucleotide polymorphism. Polymorphism means that there are different forms. You have different variations. So, but when the variation results in something that is clinically important or clinically palpable, let me use it that way, there is going to be a problem. So in schizophrenia, they said that there are so many SNPs, we call them schizophrenia candidate genes, that in the genome of people who have schizophrenia, you have these minor changes in nucleotides. That when you put them, but if you're considering them singly, they don't predispose to schizophrenia. But when they are many and you coalesce their effect, they increase the risk of schizophrenia. Do you understand? So that is the genetics of schizophrenia. That nucleotides associated with neurotransmitter release or neurotransmitter metabolism, when there are minor changes in their sequences, these changes can coalesce to predispose to psychosis, and this holds true to other psychiatric conditions. So if the protein that is the gene product is a neurotransmitter like dopamine, there's going to be a problem because the protein is not going to behave exactly as it should. When there is a problem with production of receptor, there's going to be a problem because the receptor is not going to be as sensitive as it should have been. So now this is SMP. So you also have what we call CMVs, copy number variants. This one is under genetics, so don't worry, our time is taken. Don't think that psychiatry is just schizophrenia and this thing. Psychiatry is highly biological. Highly biological. Would you neuroanatomy, neurochemistry, genetics, and all that? You need to be able to understand all this so that you'll be able to understand the pathophysiology of the illness. So now, under the genetics of schizophrenia, you have schizophrenia candidate genes, which are SNPs. Multiple SNPs that are found in the genome of people that have schizophrenia. That when you coalesce them, you coalesce their tests, they significantly increase the risk of developing schizophrenia when the person is acted upon by nurture, which is the environment. You understand? Because two people can be exposed to stress. One person is strong, does not break down, while the other person breaks down. The person that breaks down most likely has those genes, those genetic abnormalities. Now the second one are the things that we call CMVs, copy number variants. Can somebody recall what copy number variants is? Did anybody get a distinction in biochemistry? Who are the people that got distinction in biochemistry? Who is Chemere now? Identify yourself. Who is Chemere now? Okay. So can you just calm down, don't, you mustn't know it. You know what copy number variants are. Now, copy number variants are changes in the sequence of nucleotides, which can be as a result of addition or deletion of nucleotide sequence. What is the difference between DNA and nucleotide? No, DNA and genes. Which one is that?
Collection of genes.
So genes are particular sequences in DNA. Do you understand? So now when a DNA, when a particular gene is supposed to be made up of maybe 10 nucleotides, and it ends up being 12 nucleotides, or it ends up being maybe 6 nucleotides. These ones are called copy number variants, where you have large changes in the sequence of DNA as a result of addition of large sequence or deletion of large sequence. So these things predispose to schizophrenia. And a typical example of that is what we call velocardiofacial syndrome, the George syndrome. You know about the George syndrome? Yes. Where you have micro deletion of long arm of chromosome 22. So people that have the George syndrome, they have almost 80% risk or 70% risk of developing schizophrenia. But these things are rare. They are not common. They are not as common as SNPs. SNPs are very common. And I explained to you the reason why SNPs are common, because even from our color, even from our characteristics, these are as a result of changes in DNA. But CMVs are not common, but when they occur, they increase the risk of developing schizophrenia. You don't even have to have serious environmental input for the person to break down. So this is about the genetics of schizophrenia. Now, neurobiology of schizophrenia, there are certain neurobiological abnormalities that are found in people that have schizophrenia, that predispose to schizophrenia. One is MRI and CT scan findings. MRI and CT scan findings. Now, people that have schizophrenia, if you have a cohort maybe 20 cohorts of people that have schizophrenia and 20 cohorts of people that don't have schizophrenia, and you do their brain scan, maybe CT scan or MRI, and you compare some neuronal structures or neural structures in their brain, you might see some differences. One is that people that have schizophrenia are more likely to have enlargement of ventricles, especially the lateral ventricles. But it's not a must to. Do you understand that everybody that has schizophrenia, the ventricles will be enlarged? But many of them, you are going to have enlargement of ventricles. That's one. Now, you have reduction in the size of hippocampus. What is hippocampus? When they mention hippocampus, what comes to your mind? What? Memory. Yeah, memory is there. Consolidation of short-term memory to long-term memory. And where is hippocampus found? Which part of the brain is it found? Is there any distinction in anatomy here? Hey, this is So where is this thing hippocampus found? Where is it found? Which part of the brain is it found? It's found in the temporal lobe. Medial temporal lobe. Yeah. Medial temporal lobe. That's also where you find amygdala. So now people that have schizophrenia are more likely to have lower than normal, as in the volume of hippocampus is shrunken, is likely to be more shrunken than normal subjects. So, and again, the overall brain mass is also likely to be reduced in people that have schizophrenia. The overall brain mass or volume is more likely to be reduced in people who have schizophrenia than in the normal subjects. And that is why you have cognitive symptoms. They teach you the symptom domains of schizophrenia. Please, it's very important. It's remaining 15 minutes. Jot it down. Symptom domains of schizophrenia before we continue. Symptom domains of schizophrenia or symptom clusters of schizophrenia. You have positive symptom domain, negative symptom domain, cognitive symptom domain, mood symptom domain, catatonic symptom domain. Is that catatonic? Catatonia. CATATONIC. So mention the things I've mentioned now. Okay. So these are about 5 major symptom domains. Now, some schizophrenia patients have exaggerated cognitive symptoms. You know what cognition is? Cognition is your ability to think, organize things, the high order cognitive function, high order brain function, executive function, planning, judgment, insights, being able to remember things, being able to have good working memory. You know what working memory is? In fact, I'm actually testing people's working memory. Your ability to hold information and process information. As I'm talking now, your ability to listen to what I'm saying and process it and understand it and ask me questions. That's working memory. So people who have impaired working memory, but it's not you. Many things can affect impaired working memory. Many things can affect working memory, like what? Hypoglycemia. That's some of people are having. Don't worry, we are finishing. So now these are the symptoms. Now for people who have demonstrable neurostructural deficits, like all these things we mentioned, enlargement of ventricles, shrinking of the brain, reduction in the volume of hippocampus. These people that have this problem, they are more likely to have cognitive problems. It's understandable because ab initio, the volume of the brain is reduced, especially the prefrontal cortex. You know about prefrontal cortex? What's the function of prefrontal cortex? Speech. No, it's not speech. Learning, judgment. That is the non-motor area of the frontal lobe. With the frontal lobe, you have the motor area, premotor area, motor association area, then the frontal cortex. That is the seat of judgment. And that is the place that controls limbic system. You know about limbic system? Psychiatry is about limbic system. Problems of the regulation of behavior and emotion. Most of the psychiatric conditions have something to do with the limbic system. Now, the limbic system is a kind of phylogenetically undeveloped, more undeveloped than the prefrontal cortex. Prefrontal cortex is higher. That is what distinguishes you from other lower animals. Prefrontal cortex applies inhibitory impulses on the activities of the limbic system. Limbic system is about emotion. Maybe somebody says something you don't like, you feel like slapping the person, you're very angry. The prefrontal cortex, which is the seat of judgment, will apply brake on the firing of the limbic system, telling you, calm down, calm down. Do you understand that? So that is why psychiatry is about limbic system. Problems with limbic system. Is that the limbic system is overfiring, or the prefrontal cortex is not firing enough? Do you understand that? So where did we stop? What did we jot? Yes. So that is that. We already know about symptoms of schizophrenia. We've mentioned many of them now. We've mentioned many of them. Now, what about treatment of schizophrenia? Can somebody tell us something about treatments of schizophrenia? We are concluding the lecture. Can somebody tell us something about treatment of schizophrenia? Antipsychotics. What is the mechanism of action of antipsychotics? So, the mechanism of action of antipsychotics explain the pathophysiologic mechanism of schizophrenia. The most principal pathophysiologic mechanism of schizophrenia or psychosis is that you have excessive dopaminergic neurotransmission in certain areas of the brain. You have dopamine 1 hypothesis, dopamine 2 hypothesis, and dopamine 3 hypothesis. But let me not bother you with that. But what he's saying is that there is dysregulation of dopamine neurotransmission in certain areas of the brain. 1, there is excessive levels of dopamine in mesolimbic pathway, and there is hypofunctioning of the dopamine pathway in the mesocortical pathway. There are 4 dopaminergic tracts in the central nervous system. Can somebody help us? 4 dopaminergic tracts. You need to understand this for you to be able to appreciate what we're saying. You said? Suprainfundibular pathway, mesolimbic, so now these are the major dopamine pathways. You have the mesolimbic pathway, mesocortical pathway, suprainfundibular pathway, and nigrostriatal pathway. Now, where we have problem in schizophrenia is mesolimbic pathway. That's the limbic system. You have excessive levels of dopamine there. Do you understand? Now, mesocortical pathway is about the cognition. That place will have low dopamine level. That's why they have what we call anhedonia, loss of motivation, depending on the kind of schizophrenia that they have. That's why I said there are symptom domains. There are some people that have more of negative symptoms, more of positive symptoms, more of cognitive symptoms. So some people that have more of cognitive and negative symptoms, you have low levels of dopamine in the mesocortical pathway. For people that have more of positive symptoms, disorganization symptoms, they have increased levels of dopamine in the mesolimbic pathway. Do you understand? Now, what the drugs that will do, they block the activities of, they block dopamine receptors in central nervous system. That is how they work. Do you understand? And that is how we got to know that there is disorder of dopamine transmission in schizophrenia. Because when people that have schizophrenia, when they were given chlorpromazine, they had symptom resolution. So, antipsychotics can be divided into first generation and second generation antipsychotics. Please put it down. Fourth generation and second. Okay, you have a question? See, schizophrenia is a very broad topic, so it's not, we can't cover everything. So, ask your question. Okay, now, mesolimbic pathway. You know, I said that mesolimbic pathway or limbic system is about behavior and emotion. Now, excessive levels of dopamine in the mesolimbic system is more in keeping with positive symptoms. Do you understand? Behavior disruptions and all that. Now, reduced levels of dopamine or dopaminergic transmission in the cortical system, that's the prefrontal cortex, is responsible for negative symptoms and cognitive symptoms. You know that prefrontal cortex is about, judgment, insight, thinking, and also drive. So when you have reduced levels of dopamine there, what you're going to have is more of cognitive symptoms of schizophrenia and negative symptoms of schizophrenia. Exactly. Yeah. So, and now this is very important in psychopharmacology, because fourth generation antipsychotics, they work more. We know about fourth generation and second generation antipsychotics. We have 5 minutes. So fourth generation antipsychotics work by blocking dopamine receptors in various areas of the brain. Any place that there is dopamine receptor blocks it, and that's why you have side effects. Because ideally, where we want the blockade is in mesolimbic system, right? Because that is where you have problem. But it doesn't have specificity. It blocks everywhere. Do you understand? That's why you can have retardation. At times, you can have psychomotor retardation. The person is dull mentally and in terms of motor activity when you're using dopaminergic blockers, which are third generation antipsychotics. Now, second generation antipsychotics, how do they work? How do they work? Serotonin. They block both serotonin and dopamine. They have more action on serotonergic receptors. And that is why when a schizophrenic patient has more of negative symptoms, we are likely going to use second generation antipsychotics. Do you understand? Because if you use fourth generation antipsychotics, it's going to worsen those negative symptoms and cognitive symptoms. But when somebody has disruptive behavior, positive symptoms, delusions, hallucinations, fourth generation antipsychotics work better. Is it? Which people? well, that's the truth is this. The truth is it. The neurochemical system of the brain is very complex. There are so many neurotransmitters that work together. You have acetylcholine system, you have noradrenergic system, you have serotonergic system, you have GABA, you have glutamate. All these things work. So a lot is here to be known about how all these things work. So it's not everything that can be described as 1 + 1 is 2. Do you understand? So the answer is no. It has not been found to be effective. What works is second generation antipsychotics, which block dopamine receptors and also serotonin receptors. So that's that. Now, you also have other treatment modalities, psychological treatment modalities, like what? Cognitive behavioral therapy. Have you heard about cognitive behavioral therapy? By the time the psychologist will teach you, he will teach you about cognitive behavioral therapy. Then you also have social treatment, where we do family therapy. Schizophrenia is a burden. If you have a relative who has schizophrenia, it's a burden. Financial burden is there, the burden of stigma and so many other things. So you need to bring in the family member, so that when the psychotic symptoms are clear, so that you explain to them, you psychoeducate them what the illness is all about, and to be able to give the person support. There's something that we call high expressed emotion. Please note it down. It's remaining 3 minutes. High expressed emotion. Now, high expressed emotions are behavioral attributes of family members or people that have major mental conditions like schizophrenia, which affect the people that have schizophrenia and cause impairment in recovery. There are behavioral attributes of people or family members of people that have schizophrenia, which negatively affect recovery of these patients. Now, high expressed emotions, you can code it with HEC. Hostility, emotional involvement, and critical comments. Comes out in MCQ. HEC. I said there's a concept called high expressed emotion. I said that these are negative attributes of family members of people who have psychiatric conditions like schizophrenia that negatively affect the recovery of these individuals. And I said that the components can be coded by acronym called HEC. HEC, H means hostility, 2, E means emotional over-involvement, and 3 means critical comment. Did you get that? Now, hostility, okay, we have a question. Please, let's hear him.
What if the history of non-compliance of the law and the doctor is advising that immediately on that patient, what would be like
no, everything has limits. Let me explain it. Can you sit down? So that's because we're running out of time. Now, hostility. Let's start with hostility. Hostility, just like the name is, they are hostile. Probably because of what the person has done in the past. The person has brought disrepute to the family, has brought stigma to the family. The person has caused chaos in the family. So they are hostile. And hostility can be manifested as maybe flogging the patient, some people are locked inside room. You understand? Because of the chaos, that is hostility. So it has been shown to affect recovery. Now, emotional involvement means that, everybody's an adult. People want to have their independence. People want to retain their capacity to make decisions about things concerning them. So, somebody who has schizophrenia is not going to be ill perpetually, especially if the person is brought to hospital on time and the person recovers. What happens is that family members still use those eyes that they used to see them when they were sick. They feel that they have lost their independence, so they become emotionally over-involved. Maybe frequent calls, trying to connect the person excessively, being overly protective because they feel that the person has lost their capacity to run their life. Do you understand? That is so. What we are saying is that everything there has to be boundaries. Do you understand? That somebody has suffered from schizophrenia does not mean that the person cannot. There are so many people, even doctors. When you come to our clinic at our federal psychiatric clinic, professors come for clinic, doctors. So mental illness, nobody is immune to mental illness. So if the person has responded, you should at least, even if the person makes mistake, you say the person can learn from mistake. Even normal people make mistakes. So the problem is that any little thing they say, maybe the thing has started again. That is critical comment. The third part we've discussed hostility, emotional involvement. The critical comments, they always critical. They criticize the person. If the person exhibits emotion, maybe he gets angry. The thing has started again. Let's take him back to psychiatric hospital. That kind of a thing. So those attributes have been shown to negatively affect the patient in terms of recovery. So that's why we need to involve the family members and explain to them the illness, explain to them what they should realistically expect from the patient. Because at times, these people, they don't recover completely. There's a rule of 1/3. 1/3 respond very, very well, go back to the society, function well. Another 1/3 respond, but at times they have relapse. Why the last 1/3 do not respond significantly? And these are people that have all those structural changes. And people that their illnesses have lasted for a long period of time. So if somebody falls into that category, do you understand? You need to get the family involved. And this is how the illness is. It's not just about psychiatric conditions. Even in medical conditions, there are some illnesses that are resistant to treatment. So we involve the family so that they will reduce those high expressed emotions. Because shouting at them or beating them or becoming emotionally involved, all those things, they perceive those things as, that they are treating them poorly. It makes them even stigmatize themselves as people that have mental illness. So it's not good at all. So even when I'm saying that, what I'm saying is not that you shouldn't ask after them how they are doing. You shouldn't give doctor report. Maybe if the person is not taking, but you need to be sensitive. Do you understand? If whatever you're saying should be to encourage the patient, to support the patient, because you already know that this patient has some form of disability. Now what he is doing, even if he's misbehaving, he doesn't know what he's doing. So it's not by shouting, it's not by beating him. Those things do not work. So with this, we'll come to the end of this thing. So I'm going to send a lecture notes. Who is the course rep? Come and have my number. So when I send you the lecture notes, you can send to them.
Attendance.
Okay, attendance. 081 06 48 78 14. Dr. Lisa. Just flash it. Do you have a biro? Can I have your biro? So where am I supposed to sign? Where am I? Okay. Okay, what's your name? Okay.
Thank you so much.
Okay, see you next time.